Thank you. It's great to be back, and it's wonderful to see all of you on this very cold New York evening. So I'm so glad all of you could come out here and join us. Last month, we kicked off our series, Rethinking Mortality, with a fascinating discussion on the science of resuscitation, and I am quite sure that we are in for another special evening. As Richard mentioned, tonight we're going to be talking about the legal, ethical, and social dimensions of end-of-life care, from do not resuscitate orders, to organ donation protocol, to physician-assisted dying, to guidelines for withdrawing life-sustaining procedures, to the cost of end-of-life care, to doctor-patient relationships. To be honest, this subject is so big and so complicated that we cannot possibly cover all the issues that might come up, but we're going to try. And we have a terrific panel to help us sort out these questions. So let me introduce our speakers. Christopher Comfort is the medical director of Calvary Hospital, which coordinates and facilitates clinical services for palliative and end-of-life care. Dr. Comfort is board certified in internal medicine and geriatrics and is a member of the faculty of the Albert Einstein College of Medicine. His research interests include advanced directives, spirituality, and palliative care. Barbara Coombs Lee is president of Compassion and Choices, a nonprofit organization dedicated to expanding and protecting the rights of the terminally ill. She practiced as a nurse and physician assistant for 25 years before beginning a career in law and health policy. As a private attorney, as counsel to the Oregon State Senate, and as chief petitioner for Oregon's Death with Dignity Act, she has championed individual choice and empowerment in healthcare. Sam Shemie is a professor of pediatrics at McGill University, medical director of the extracorporeal life support program at the Montreal Children's Hospital, and he's the Bertram Loeb Chair in Organ and Tissue Donation at the University of Ottawa. Dr. Shemie's area of specialty is organ replacement during critical illness. He's been involved in developing guidelines for organ and tissue donation and transplantation in Canada. And last but not least, Mildred Solomon is president and chief executive officer of the Hastings Center, a bioethics institute which analyzes the ethical issues in medicine, healthcare, life sciences research, and the environment. She's also a clinical professor of anesthesia at Harvard Medical School, where she directs the school's fellowship in medical ethics. She does both research and policy work, and she has trained bioethicists from around the world. Welcome, all of you.
Thank you.
Millie, let me start with you. Why is end-of-life care such a hot issue now?
We are dying in ways that the human species has never died before. In a relatively short period of time, a few decades, about 50 or 60 years, the way in which humans die has been transformed. We used to die from acute infectious diseases or injuries, and in ways over which we had very little control. But modern medicine has changed that, and now in the developed world in particular, we are living longer, but it's a Faustian deal. We're living longer, but with long chronic illnesses that progress, and during which we become more frail. And the kinds of technologies that have enabled us to live longer also present very difficult choices about how best to use them. They've been called halfway technologies because they can't always restore us to where we'd like to be, but they can keep us going. And so that raises all kinds of questions about how to use them so that we benefit from them in all the ways that we want to, and they certainly do bring us enormous benefit. But it also requires really careful reflection about when the burdens may not be worth the benefits.
So is this basically a question of we have all these technologies at our disposal now so we can keep people alive longer than we ever could before? So there's obviously the ethical dimension there. There's the question of, should people stay alive when they're in horrible conditions in some case? Is it at that level, or is this also a financial question, a financial issue?
Things exist both at the individual and family level and at the societal level. As a society, we've had to come up with a sort of framework to guide us about what's ethically and legally permissible. And that's something that has evolved over about 25 years. The Hastings Center has been involved in creating that framework, and there's been many, many court cases. So we've had a societal framework for doing this, but then it has to get played out at the family level. In the United States, we've given enormous discretion to individuals to make these decisions. We believe that we should be self-determining, we should have a lot of opportunity for choice. But in the aggregate, all of the way in which we've built the system and giving all that choice hasn't really been designed in ways that necessarily think about our common good. And that's where the financial picture may come in, because if we have designed a healthcare system that is mainly focused on providing highly technical, highly specialized care to patients without any guidance about how to make the best use of that, and we've put much less emphasis on lower tech, more high touch, if you want, more labor intensive, that might be actually better for all of us in the long run and maybe even have an impact on cost. We haven't designed that system yet. So there's an interplay between the freedoms that we want to have to make our own destiny and how to design a system that is really in our best interests and also takes cost into account.
Chris, let me turn to you. You are on the front lines of palliative care. What do you see as some of the most difficult issues that you have to deal with and that you see others needing to deal with?
Yeah, I think one of the issues that are germane to the idea of death and dying, and the idea that we've got an armamentarium or the ability to impact that one way or the other, has to do with promises made. And I wonder if many of the technologies that we have end up being promises to patients and families that, in fact, an inevitable event is not going to occur.
Do you mean the promise or the hope that there will be a cure down the road?
Well, I think different than that. Let's take, for example, the session that you had on resuscitation last time, where you introduced the idea of new technologies that, in fact, make resuscitation successful, and you can restore individuals for time with their loved ones when you didn't expect them to survive. But here in New York City, if you look at success rates of resuscitation for on-the-street collapse, you are somewhere at about 1.8% for successful resuscitation. If you look at resuscitation in a hospital setting, even in a tertiary center, you're looking at resuscitation rates that probably peak out at about 30% for the entire population as a whole. I take care of cancer patients who are at the end stages of their illness, and if you look at success rates of resuscitation in that population, in a hospital setting, it's less than 5%. So when we talk about something like resuscitation, or we talk about something like new chemotherapeutic interventions, or we talk about new technologies in terms of surgical interventions, I think it's very, very important for us to be clear as a medical community what it is that we're offering, and then looking at those success rates and translating that information to both patients and families, so that what we're offering are not promises of success that are unrealistic and not borne out by the actual evidence of what these interventions have to offer patients and families, and then have the tough discussions about what are the benefits or what are the risks of the interventions that we're talking about people taking. You know, at end of life, the way I always look at it is you've got one chance to influence living. Because I've had a hard time understanding a good death. It's easy for me to understand what living is like before someone dies. And it's so important during that period of time to make sure we're meticulous and very careful about not only the choices we offer, but the information that we give, because it is such an important sacred time for patient and family.
You used the phrase, a good death, and I think we should unpack that idea. Sam, let me bring you into this discussion. What is your idea of a good death? What makes a good death?
One that you're not there for, perhaps. I'm probably not the right person to answer that question. I want to give some context. I'm a scientist and an interventionalist and a technologist. I work in an intensive care unit and run a team that deploys heart-lung machines to sustain life. And I would like to draw a distinction for the panel and the audience. There is a big difference about end-of-life issues related to chronic terminal care, terminal illnesses, versus acute catastrophic illnesses in previously healthy people. And it's important to really distinguish those things. I think everybody would agree for acute catastrophic illnesses in previously healthy people, we should be providing everything that we can to sustain life in order for either a treatment to be effective, time to be effective, a surgical intervention to be effective, to reverse that life-threatening situation. Very different than the chronic terminal phase of an illness in which you have to make a decision about what will be provided and what will be withheld. And we know that in our society, and I'm from Canada and it's equivalent here in the United States, that the vast majority of all deaths in our society currently are preceded by a decision not to provide a treatment or a decision to withhold a treatment. And in the vast majority of those situations, it is a reasonable discussion with reasonable people that come out with reasonable decisions. There are a number of exceptional cases where conflicts between healthcare providers and families and individuals are there that get inflamed in the media, that exaggerate the severity of the issue. But in most cases, when you speak to families and people towards the end of life after chronic illnesses, and as long as you're honest and have a trustful communication with that family, the correct decisions are being made. So what is a good death? As pain-free and as suffering-free as possible, as well-informed as possible in order to make that decision. And you ask people, they want to make sure they're not a burden to their family and their affairs are in order before that happens. That's certainly when you survey the public in our country, that's what they say.
Barbara, let me bring you into this discussion. You have worked with patients who have had these long chronic illnesses, who are terminally ill. What's your definition of a good death?
A good death is one that honors the life that's been lived, I would say, and that depends on a person's values and beliefs, indeed the life that they have lived. You know, if you think of a life, like a play, and the play was fantastic, it was meaningful, the acting was terrific, the characters were compelling, the meaning was persuasive, it was deeply moving, and the last act, everything just went all to heck. And nothing really culminated. There was no really pinnacle. There was no catharsis at the end. Or it was a devastating experience, and everyone in the theater left with post-traumatic stress syndrome. That's not a good play. A good play, like a good death, is one that is of a consistency, and the ending of it is an honor. You know, I often say that death is not something to be run from because it is inevitable. We cannot run from it. But it is something to be worked toward. We can all live our lives every day, and that's really what it's about. It's about sucking all the sweetness out of life every minute and every bit of meaning out of our lives so that when death becomes imminent, it doesn't seem premature. It doesn't seem as though we haven't lived. So I would say a good death is one that seems appropriate, it seems right, it seems like the life has been lived, the meaning has been had, and the death honors that.
I'm guessing that all of you would agree with that definition, but it's not as simple as that. And I guess the question is why? Why is it that, I mean, obviously death, almost by definition, is going to be difficult in many situations, but why are there so many cases where it would seem that people live longer than they should, or that in some other cases family members feel like more extreme measures were not taken? Why do we have these kinds of problems, Chris?
Well, I think a couple of issues that we've seen that help us to define the practicalities of the specifics of what we think of as a good death, which I don't even pretend to know what it is. First question that I would ask is location of death. It's interesting, we train medical people at Calvary, and they'll come in, and since we take care typically of cancer patients who have been ill for long periods of time, the first question we'll ask them is when you get your lung cancer and you're failing, where would you like to die? And universally everyone will say home. And then I'll look at my latest statistics here in New York City to see that for 15,000 cancer deaths in New York City, there are 2,700 deaths at Calvary, there are 3,000 deaths at home, and there are 9,000 deaths in hospitals in New York City. And I'm confused. It's a chronic illness. It's anticipated. The decline, in fact, is fairly demonstrable. Yet the sight of death for someone who, when we poll individuals who say, where would you like to spend your last days, ends up being different than what they say when it is before that time.
So why? Why aren't there more people who actually do die at home then? Millie?
Can I jump in?
Yeah.
So I think it's one of those, perfect problems because there's many different converging reasons. One is the way our healthcare system is built. So these cancer patients have seen specialists. They've been treated perhaps obviously by an oncologist, but also we tend to slice up and segment the way in which we provide care here. Our whole system is designed as a set of specialist encounters without anybody really taking patients under the wing and helping them understand their situation, navigate the system, and think about their own goals of care. There's a strong empirical evidence that physicians collude in this too, in that when they do have a sense of a dire prognosis, they don't share it very early.
So you're saying there are certain critical discussions that need to happen,
don't happen
between physician and patient, or perhaps between physician and family, and just things are not being discussed.
For example, there was a study of women with metastatic breast cancer. 85% of them had discussed their situation with their family and friends and said they wished they had had a conversation with their doctor, and only 19% of them had. So something's not happening in the exchange that's really honestly framing what your situation is.
Why not? Why aren't doctors having those conversations?
Well, certainly oncologists tell us, and we've done some studies on this, that they feel that they're just that there's a concern about reframing people's hope or dashing people's hope, and that's unfortunate.
So the idea is that you don't want to tell people, oh, it looks like you have 6 weeks to live,
and you don't want to be the one to tell them both. And we're here to talk about meaning, and I think one of the big takeaways for me is that people can take meaning out of their situation if they understand it and there's somebody there to accompany them. And hope can be reframed. It can be hope for the sorts of things that Barbara was talking about, for life closure, for me to deal with the regrets I might have about my relationships in my family, to say farewell, to tell my kids what I want them to know for the my words of wisdom for the next generation. We don't create a space for that kind of meaning to occur if we are only looking at the technical aspects of our care. And we don't have any structures in our healthcare system to have that kind of, the honesty and breadth of that kind of conversation, and nor do we have anyone to sort of travel with you as you go through this trajectory. So,
in defense of doctors, because I feel compelled.
I set you up.
You did, thank you. When you film interviews between physicians or nurses and families during periods of crisis or during giving bad news, there is a big difference between what is told to the family and what they hear. And there's certain words that kind of shut people's minds off. Words like cancer, once he said that, I didn't hear anything else that he said. And the reality is, communication is two ways. It's true that when you survey families, they say, I wish they had told me this. But when you survey providers, they'll say, well, we talked about it, but they didn't receive it. And so in defense of communication from healthcare providers, I think we know when we talk to families, the reason that we repeat things frequently in different meetings is because it is difficult to take everything in, and the style of communication impacts profoundly on what families hear and are able to process. And it's true that different providers, depending on the technology of the wording, may or may not be better communicators. And I'll bet you Chris is an excellent communicator. Based
Well, Sam's
on what
exactly
he does.
right. And we have the rule of 5. You say it the first time and you assume nothing was heard.
Right.
You say it the second time and maybe something was heard. And by the time you get to the 4th or 5th, you know that what you've said hopefully has been appreciated. And then you can use some techniques of having repeating back that families tell you. More importantly, I think, is the idea of incorporating difficult discussions about prognosis into, this going to the idea of how do you reframe hope, having those discussions in terms of here's the reality, which is the reality, and how does this influence or how does this change your planning? I always say that when I get my lung cancer to my brain, somebody tell me, because I'm going to take my beach chair, I'm going down to Key West because I've decided how I want to spend my time. But for me to make that decision, somebody has to tell me what the prognosis is.
That's right.
And then it becomes important because it's not just cancer, which is easy because cancer you hear and that's everybody goes. But see, when I get my class 4 heart failure, you got to tell me the same thing because my prognosis is the same as my lung cancer to brain. And if I was going to take my beach chair to Key West if I had lung cancer, wouldn't I take my beach chair if I had congestive heart failure? So
Is it the obligation of the physician to be as honest as possible in terms of delineating what the prognosis is?
I think it's important for the discussion to occur, and the way that we start that discussion is that we ask. And so it's important, I think, to position yourselves in discussions with patients and families, not that the agenda is information giving, but the first agenda you have is to understand where is the patient and family and what is their level of understanding. It's fascinating with patients with chronic illnesses who really adapt very well to the limitations that they have, that they are usually fairly accurate in telling you what their experience has been and where they are in their understanding of the disease process. When you frame it that way, then it's a discussion about what they already know, or it is a gentle correction to their misunderstanding of how they feel.
Barbara, do you want to jump in here?
I was going to say that the reason these discussions are so difficult on both sides is because there is this societal acquiescence in the myth that death is optional, that death is never appropriate. If there is any option other than death, that's the appropriate option. Death is never appropriate, and that's just not the truth. Sometimes a gentle, a peaceful closure is the appropriate thing to happen. And once that's out on the table and people can start talking about, okay, how can we make this as anticipatory and gentle? When is it time to take the beach chair? Then all kinds of wonderful things can happen in terms of closure and comfort and life meaning. But it can't happen when you're not allowed to acknowledge that the time has come. Death is appropriate now.
I agree with Barbara, but if I can, there are 2 factors that influence that decision. One is there are many situations where doctors and healthcare providers are certain about the prognosis. But there are many situations where that certainty is not as clear. And that uncertainty makes those decisions a little bit more difficult and confounded. The second thing is the public perception of the capacity of healthcare and technology to prolong life or to save life is disproportionately exaggerated from the truth. Chris was quoting cardiac arrest survival rates that are true, but there was a study a number of years ago in New England Journal that looked at the television the way television shows give information to the public about cardiac arrest survival. So they surveyed a number of TV shows at the time, Chicago Hope, ER, and the survival rate from cardiac arrests on those shows was 70%. So the idea versus a less than, what did you quote, Chris, there? 1.8% of out-of-hospital cardiac arrest. So you can understand why the public perceptions. And when we market, if I can say that, contributions to research and to what we do, whether it's transplant or cancer care, there is a disconnect between actual prospects for recovery and survival versus what the public perceives. And then you juxtapose that to prognostic uncertainty in situations and technological capacity, and it's fairly predictable why we have these discussions and these.
If I could say a word of language just very quickly. So physicians, medical establishment brings it on themselves a little bit, even when we talk about resuscitation. We're going to, do you want resuscitation? Well, who would say no? Of course I want resuscitation. Why not say attempted resuscitation? Because an attempted resuscitation is all that can be offered, and 9 times out of 10, 99 out of 100, that attempt will be unsuccessful.
And I would go further, because this is a good example of how we've designed the system to undermine our ability to really be clear about situations. So with regard to do not resuscitate orders, the way in which we do this, the default is that you will get cardiopulmonary resuscitation. That's the default, whether or not it's likely to be beneficial to you.
What if the patient or the family has signed the do not resuscitate
But
papers?
the default is that it's going to be offered unless you say that you don't want to do it. We could actually design a system in which that was reversed. For certain patients, those where there's not the prognostic uncertainty, but where there is imminent dying, we could encourage clinicians to go to the patients, disclose that they're not recommending cardiopulmonary resuscitation.
Attempted.
They're not recommending, yeah, exactly, to attempt this because they want to protect. I want to protect you from the burdens.
But isn't one of the challenges here, you're cutting against the grain of what doctors have been trained to do, which is to save life.
And American culture, cutting across the grain of American culture, which sees solutions in technology,
I know,
rather than in relationship and in some of the other non-tech, other kinds of ways we could design the social supports that people need. So we go first to a technological fix. That seems to be deeply in our culture, and then we train our doctors that way.
But you want to live in a culture that has an attitude where technological fixes are important, because the science and technology of healthcare has advanced profoundly to the benefit of many people for many years. And so we're talking about the appropriate utility of those interventions when there is no prospect for recovery. And absolutely, but having said that again, in North America, the vast majority of deaths are preceded by a decision to stop or not provide treatment, including CPR, including DNRs. These are discussions that occur every day. And these are, and again, in the majority of cases, these are reasonable decisions made by reasonable people. But we have all at the bedside are faced with families who refuse to accept what you say, who insist on the deployment of those interventions, either CPR or continuing life support interventions. And you're right, CPR is very different than surgery. So a surgeon can unilaterally say, I'm not going to offer this surgery to you because I think it's not in your interests. And there is no recourse of that family other than to get a second opinion. But cardiopulmonary resuscitation is different. The default is to provide it because we don't want to make mistakes of not providing it in situations where it can help people.
It's so interesting to hear physicians talk about the compelling, the train of treatment, of aggressive, burdensome treatment leaves the station because the family is pushing it. And the families overwhelmingly will say, no, we thought that that was the only option. We thought this is all that the physician offered. The physician didn't talk with us about palliative care, and indeed that has been borne out. There was a study in the intensive care units of a number of hospitals that listened in on the family consultations of patients who had already been in the ICU for over 2 weeks, who had terrible scores that indicated they were overwhelmingly likely to die during the hospitalization. 70% of them actually did die during the hospitalization. And they found that whether or not the physician talked about a palliative care option was completely unrelated to the diagnosis, the prognosis, the Apache score, which is this ICU survival score, the age of the patient. It was related to only one variable, and that was whether the physician himself or herself believed that that was the choice that the family or the patient should make. But there's no right or wrong answer to palliative option at the end of, for example, a cancer course. It has to do with the values and the beliefs of the patient and their family members.
So
But in
wait, so
fact-
just so I understand what you're saying that there are many cases where the family has made it clear that they do not want these life-sustaining measures taken?
No,
No.
I'm saying that there are many, many cases where the family doesn't know that that's even an option. They don't know to raise their hand and say, oh, is there a comfort option here? Could we be talking about comfort care for grandpa who's 95 and dying of heart failure?
A lot, this is unspoken, but a lot of the goals that occur in these conversations that aren't managed by expert palliative care physicians, but are a sequence of specialist conversations in hallways often, without the kind of conversation that should happen, is that the goal is to get the patient to discharge. Let's be honest. I don't think my...
When I go to the hospital and I'm sick, I want to be discharged as soon as possible.
but you know,
That's okay with me.
Yeah, well, it's not okay with me if it means that I may be going to be having some brain damage from what I'm going to be agreeing to, or I'm going to get a trach and a peg and then sent to the nursing home without having a conversation about what happens when I'm discharged. So the greatest, one of the takeaways I would hope for people here is if you're in a situation where you have a loved one where it is a very dire situation, or you suspect it might be, it's to put a little pressure on one's clinicians to ask, what's the likely trajectory of my illness after I leave the hospital? Where do you think these choices are going to, what path am I going to be set down if I go this way versus if I go that way? And to give your clinicians a chance to acknowledge their own uncertainty about it, to say, it's okay, doc, if you don't really know what the diagnosis is, but can you help me think through what these different trajectories are likely to be after I leave here? And that might affect what you decide to do while you are here.
I just, again, in defense, no, not at all. I just want to elaborate because it really depends on where the phase of your care is through the healthcare system. If you're dealing with your surgeon is more likely to recommend surgery because that's what they do. But in terms of intensive care life support and whether or not it should be started, continued, stopped, the reality is right now, the conflicts in that setting are related to families insisting on continuing and clinicians trying to stop. It is no longer, historically that was true, that it was doctors pushing the treatments. But that's not what's happening in any modern intensive care unit. And if you look at studies of anywhere, US, Canada, Europe, what you said is absolutely true. And that is, what you want to be able to do is to make a decision in the interest of that patient based on patient factors. How sick they are, what their values are, what their prognosis is. But what you said is true, is that the characteristics of the physicians influences the decisions or the recommendations that are being made. And that depends on age, specialty, geography, religion. So there was a large study in Europe comparing Northern European countries and Southern European countries based on the religion and characteristics of the physician making the recommendation for stopping treatment before death. And the message was, if you want no treatment in the intensive care unit, you got to find a Jewish physician from Northern Europe. And if you want everything done to you before death, you got to find a Greek Orthodox physician from Southern Europe. And it's true that physician characteristics clearly influence the recommendations. And how to distinguish those two in terms of public information and discussing with your providers, make sure you understand the perspectives of the person giving you the advice.
Well, or insist on a comprehensive disclosure, and that actually is the law in the state of New York. New York is one of 2 states in the Union that have disclosure laws that say when a patient is terminally ill, the physician has a legal duty to reveal the whole compendium of treatment options. You shouldn't have to press for, is there a palliative care option, doctor? It should be laid out in front of you, because it's not the doctor's decision. It really is your decision. And if you're the surrogate decision maker, it is your decision. It's not the physician's to make.
Chris?
And I think this is an interesting point, because New York does have what's called the Palliative Care Information Act, which was passed a couple of years ago, which says exactly that if the prognosis is thought to be less than 6 months, that is the obligation of the physicians. And it's interesting because it is not just the attending physician, but any doctor who deals with that patient during that stay in the hospital and the nursing home is obligated to have a discussion of offering resources of palliative care. You know, we've been playing a trick on oncologists now for about 10 years. We have an application for an end-of-life facility with a length of stay of 26 days with cancer patients, and we ask the oncologist to predict the survival of their patients. It's fascinating because we take care of cancer patients from the finest programs in the world. And so we look at the patients and we divide the patient survival into quartiles, and then we try to match the quartile that the patient survives with the prediction that the oncologist made. In fact, typically the oncologist is never right. So the question I have for you, does the oncologist underestimate or overestimate survival?
Overestimate.
What do you think? And in fact, typically we'll overestimate, and overestimates now by about, last year was about 250%. So 6 weeks survival was 2 weeks, 6 days was 2 days. It's fascinating. We have 12 physicians who've worked for an average of 18 years with us, who do only end-of-life work. That's their specialty, it's their business. And so we did the same thing to them. How long is this patient going to live? And we looked at their predictions and matched them up to patient quartiles. They never got it right. Did they overestimate or underestimate? They overestimated. They overestimated by 150%. And I think what we've come to learn is that it's a tricky business to take a look at an individual patient and have an idea of what a prognosis is. And we've come to understand that most of our predictions of prognosis have almost nothing to do with looking at the patient. It's fitting the patient into population data of survival, which makes it then very difficult, because now you're talking about looking and having discussions about prognosis in very difficult situations. Take cancer, for example. The decline is significant and fairly predictable, obvious to the patient, because of how the patient feels, usually obvious to the family. But you take another fatal illness, heart failure, and heart failure looks like this. I mean, you're good, you're bad, you get to the ER, you get some Lasix, you're good, you're bad, you're 3 days, you're good, you just don't show up the next. 80% of the deaths in heart failure are sudden death. How do I have a discussion with a patient and family about a poor prognosis?
That one's hard.
When I can't identify the time of death because the method or the cause of death is unpredictable, yet I still have that obligation to give the knowledge of poor prognosis so that patient and family has the opportunity to make the decisions they want to make.
I want to jump in here because we have so much to talk about still, and we haven't even touched on some of the issues that we have to talk about. Physician-assisted suicide. Barbara, I know you don't like that phrase. You prefer physician-assisted dying. This is, now legally, this is allowed in only 3 states in the United
Well,
States,
it's an
right?
inaccurate phrase because suicide does not describe the decision, the rational end-of-life decision that patients are making. Specifically under the laws where aid in dying is legal, specifically it is not suicide, and so it doesn't qualify as suicide in insurance policies, etc. But beyond that, suicide is an irrational act. It has to do with mental illness. It's not a medical practice. So to label aid in dying a medical practice with the terminology of a crime is kind of like saying, well, surgery, you might call it surgery, but I prefer to call it mutilation. And I think that's a felony. So mutilation or stabbing, well, no, you wouldn't call surgery mutilation or stabbing. That's a crime. But there is a medical practice of surgery, and so that's what we would call it. We would call it surgery. So it's the same thing with suicide, that assisting a suicide is a crime. It should be a crime. You shouldn't be goading or influencing suicidal people into destroying self-destructive behavior. But people who are not about self-destruction, but who are about actually preservation of the integrity, of the coherence of the story of their lives, who do not want to slip into the final degradation of delirium or unconsciousness or uncontrolled pain or some other thing that is abhorrent to them and would qualify to them as a violation of everything that they stand for. That's not suicidal.
Can you give me a concrete example of this, to take the state where you come from, Oregon? What is allowed there in what you describe as physician-assisted dying that would not be allowed in most states?
Well, what is recognized and granted specific immunities in Oregon and Washington and Vermont and Montana is that a patient who is eligible, who is mentally competent and terminally ill, can ask their physician for medication, a prescription for medication that if they were to take it, that it would cause a relatively rapid and a peaceful death. The obtaining of that medication, as it turns out, we know from 20 years of experience in Oregon, is the pivotal event that transforms the quality of life. People feel empowered, they feel relieved of the anxiety about how they will die, how horrific it might be for them, how traumatizing it might be for their family if they want to die at home. And as it turns out, 30 to 50% of people who do go through all of those processes to become eligible, do receive the medication, don't take it. They die with the medication under their pillow, in the refrigerator. They say that was the important thing, that they achieve control, they achieve comfort, peace of mind from that, and they go on to die of their illness, usually in hospice care with palliative support.
Millie, I know this is an issue that you work on as well. What's your take on this?
Well, I think that there's a lot of, obviously there's strong differences of opinion. We haven't reached a consensus across the country, only 4 states right now. There is a move that we can see, and it's going to come up in other states soon. But we know from Oregon that at the end of the day, aid in dying or legalizing assisted suicide is only of interest to a small number of people. It may be that as a community we decide we want to legalize this on a broader scale, but it's not going to fix the way in which we care for people throughout our society. It's going to be relieving for the people for whom it's relieving, but that's going to be a small percentage. And what we have to do is think about how we're going to redesign our entire system of care to care for this huge aging population that we've got, most of whom are not going to turn to this as their remedy. And I think we have a societal obligation to redesign the system so people are not terrified that if they don't have this medicine in their fridge, that they're going to die alone or in pain. This is not an acceptable alternative. It's an obligation we have to redesign the system for the majority of people.
I would just say that in Oregon, 1 in 6 patients asks their family, begins the conversation with their family. They know that they're dying, they're starting to plan for a peaceful death, and they have the conversation with their family. Would you support me? I'm interested in this death with dignity thing. That's a lot of people, 1 in 6. Exactly. And the ability to take the taboo away from the conversation, put, as we said, the appropriateness of the time of dying on the table is an enormous benefit, and the Death with Dignity Act does that.
Those aren't the statistics I've seen, so I'm curious about
1 in 6.
who's the denominator there.
1 in 6 begin, this is from Linda Ganzini and Susan
Yeah.
Toll, 1 in 6 has the conversation with their family, 1 in 50 has the conversation with their doctor, and 1 in 500 takes the medication and dies that way. So but it's not about
Yeah.
the 1 in 500. The 1 in 500, you're right, it's a very small number, but 1 in 6, that's a large number.
I'm guessing we're going to come back to this issue maybe in the Q&A session. I do want to make sure we talk about organ donation, which is Sam's
Yeah.
specialty here,
Right.
which we haven't even touched in any detail. There is sort of a rating protocol, what is called the dead donor rule. Do you want to explain how this works?
Yeah, it's basically there as a moral and in some jurisdictions a legal obligation to make sure that you don't harm a living patient by removing their organs or kill them, that somebody has to be dead before you remove their organs to benefit somebody else.
It makes sense, right?
Sure, it certainly does to me.
Now, does that inhibit the maximum use of organs that are made available for transplantation?
So, if you look at the inverted pyramid of everybody who is likely to die versus everybody who's dead, if you look at it from that point of view, you would say, as somebody on the transplant side of things whose interest it is to provide transplant to their people who are on the waiting list who have a high risk of dying on the waiting list, you would say, well, if you're going to inevitably die, why isn't that okay and you want to donate organs? You're going to inevitably die. You've said you wanted to donate organs. Why can't we take organs before you're actually dead? I personally have a big problem with that. I think that is a large gray area of practice. We're talking about uncertainty of prognosis that we already have in the dying phase and terminal illnesses. And for me, the dead donor rule is sacrosanct. It is the foundation of professional trust. It is the foundation of public trust that we are going to try to save your life when we can. And it's only when you are dead, not maybe dying, that we will approach you to donate organs. And the organ donation and transplant system will fail if there is no public trust. It is based on benevolence of people and the willingness to help. So I am a strong believer in the dead donor rule. I think the discussions that are out there are more of an academic debate than they are a real policy or practice debate.
But isn't there a question about how we define death? I mean, what is the moment of death? Is it the death of the brain? Is that the determining factor?
I am currently, in fact, working with the World Health Organization to develop international guidelines for death. And there is an evolution in what we understand, I believe. Historically, this issue of brain death, or what is the irreversible and complete cessation of all functions of the brain, is historically, when it started in the late 60s, was very controversial. It was this new thing. It was a result of advances in transplantation, but more a result of advances of all these life support technologies that keep bodies alive but can't help change illness. And but as time has gone on and technologies have continued to advance, it all is kind of converging into one singular definition of death. This is my own personal opinion, not a policy opinion. In the United States, there's two determinations of death. It's either after your heart stops or after your brain stops. But I think we are converging with this advance in technology to center it on the brain. Everything that we are is related to the functioning of the brain, and when your brain completely stops working and will not resume functioning, that is effectively death, whether or not your body is supported by organ support technologies or not. And you arrive there because you have a brain injury that destroys your brain, or in fact you arrive there because your heart stops and no longer delivers oxygen and circulation to your brain. And those are the two paths to go there. So yeah, I think it's all about the brain.
Yeah, Millie?
There is a debate in the scholarly literature on the dead donor rule. But no matter how that comes out, I don't think it's going to make a big difference in terms of the number of organs that are available. But there is another distinction that I think people should know about, and that can actually be another resource for families who want to contribute. Most of the donations now of people who have died, I'm not talking about living kidney donors or something like that, but among the deceased, are from those who have died by brain death criteria. But increasingly, we are sort of opening the opportunity for families to decide to donate for people for whom there has been a decision to withdraw life support. And so you would say that that's donation after circulatory determination of death. They are not brain dead. They might progress to brain death because they're eventually, but they are there's a family decision to withdraw treatment, and the family has decided after that, they can be approached about donation. And right now, it's a small percentage of the organs that are received that way, but that is growing. Many hospitals around the country have created policies for donation after circulatory determination of death. And as families become more aware of it, this is something that you can actually ask about. And it's directly tied to your comment about, a very large percentage of deaths do occur. The timing of that is a conscious decision. And if the timing is a conscious decision, it can create the opportunity to make the next decision that once we're withdrawing care, we're allowing the person to die, and we'd like their organs to be useful. So that's a sort of a new trend.
Yeah, it's a complicated issue, and in fact, in the United Kingdom, almost 50% of their donors are donors in this way. And so there's no question the potential benefit for transplantation is substantial. But it does raise the issue of this intersection of decisions to stop treatment or decisions to assist dying, and how they may in the future intersect with can you donate organs under these circumstances. Now clearly people with metastatic cancer are not eligible to donate, but certainly people with terminal illnesses certainly are, that are not cancer related. And so the next future discussion that's not really out there yet is, can you be a donor of your organs before you agree to either stop treatment and die or receive a treatment to die, as a living donor before you die, or as a take your organs as I'm dying? And those future discussions are even going to inflame and confound the situation a lot more, and we'll need a lot of sober thinking around it. So,
in a minute, I want to go to our audience here, but before I do that, I want to sort of ask each of you whether, if there is one thing, one policy change you could suggest, one protocol change in terms of end-of-life care, what would it be? What's the one thing that you care passionately about that we could do better? Chris?
I think we could do better with the foundation of moving end-of-life discussions to the generalist level rather than a specialist level. I'm not a specialist in palliative care, although everybody says I am. And that the discussions of prognosis are a fundamental part that goes on between physician and any patient they take care of. And with the wonderful conversation of you've got a great prognosis after a myocardial infarction at a young age from single vessel disease, to the discussion of a poor prognosis in someone who has metastatic cancer, where you can anticipate that even with aggressive interventions at palliation with chemotherapy, the result is going to be death. So not that the discussion of prognosis has to be a bad discussion, but that physicians and caregivers start to look at all of their discussions about the care that goes on with their patients in terms of understanding prognosis, because I think it's so fundamental to the way we set goals of care with patients and families about what we're going to do as we move forward.
Barbara, what would you like to see changed?
I'd like to see the attitude change so that family members, surrogate decision makers in a time of crisis have the wherewithal, feel empowered enough to ask, is it time to talk about a comfort option? So your dad, 93 years old, just fell, he hit his head, he is bleeding into his brain, the prognosis is very poor, we want to put him on a ventilator, we want to transfer him to the ICU. Is that okay? if a family is empowered to say, is it time to talk about a comfort option? Is it time to talk about planning a peaceful death? So that that 93-year-old doesn't board the train of aggressive therapy and have the train leave the station, and pretty soon you're in an ICU and it's 10 days later.
Millie, what would you like to see
I would
changed?
like to revisit a piece of the Affordable Care Act legislation that came out in the summer of 2009. It intended to reimburse physicians for the kind of conversation that Chris is advocating as part of their professional services. And it came out for reasons that were inappropriate in my view. And it will be a single policy change at the national level that could change the behavior at the local level.
Sam?
I think that we have to, we didn't get into this too much, and that is the issue of resources and the ability to sustain what we do. I love technology. I believe in science. I believe in a singular dedication to advancing science because it does benefit. But there is a massive cost. And if you look at the cost of end-of-life care in the terminal months of a person's life in the United States or in Canada, it is a huge proportion of the healthcare budget. And so we can't, at the bedside as a clinician, make resource allocation decisions when we're faced with a patient or a family. Our default is to save life and provide that option. However, there needs to be, I believe, a real reflective discussion about what is the financial capacity to sustain this in our societies, given the demographics of the population and the exaggerated problems that we're going to be talking about as people age further. So I think there needs to be an honest discussion about the cost and what is worthwhile and what can be done versus what should be done.
Okay, it is time to hear from you, and why don't you raise your hand if you have a question, and there are roving mics back there, and I will call on people. Let's go back to the gentleman right over there.
I think what you're talking about is countries like France and Spain that have presumed consent, which is it is presumed you're going to be a donor unless you opt out. You know, I think North America is different now. When we survey our public in Canada, it's almost split 50-50 in terms of public opinion about whether presumed consent is consistent with Canadian values. But I would tell you that in general, personal autonomy is a much greater value in North America than the cultures that you've mentioned. And that personal autonomy, I think, would go against any government driven initiative to perhaps remove that autonomy. Certainly politicians, in a superficial response, when they're faced with the donation crisis and the insufficient number of organs, etc., they'll say, why don't we go to presumed consent? They're going to try it in Wales after the rest of the United Kingdom decided not to pursue that. What we know, though, is that if you invest in the donation, before that policy change, I think investment in the donation system, personnel, public awareness, consent registries, in many countries has been very successful in increasing donation rates that compete with European countries.
Can you just back up for a moment and explain how presumed consent works? So the family would have to say no, or the person would have to say no, you cannot harvest these organs?
I mean, the policy is you're a donor unless you indicate otherwise. Now, there are some countries who actually allow you to register your desire not to become a donor. But Spain doesn't do that. Spain has the highest donor rate in the world. What they say they do is that regardless of the presumed consent legislation and the opting out, they provide the option to families to opt out. They always get some form of consent. However, presumed consent effectively reflects the societal perspective on the issue. Presumed consent means really your society kind of supports it in general. And so they'll say it's not a significant factor. I believe it is. But you can, if we've surveyed in our research group different countries with different consent laws, and donation rates vary profoundly. In general, presumed consent countries have higher donation rates, but there are countries without presumed consent, informed consent, opting in, that have very high donation rates. And you can look at Philadelphia as one of the world leaders in a country that doesn't have presumed consent. So there are other ways to do it, but you tell me whether the public would embrace that in New York. No? Yeah, I don't think so either.
The Institute of Medicine did a study on this several years ago, and their report said that they thought it was a very ethical framework, but one that the American public wasn't ready for. And we've mentioned autonomy. I think another factor is a lack of trust that we have in our institutions. We have a lack of trust in our government. We have a lack of trust in a variety in each other, and we don't have the same sense of we don't even have the word solidarity, which is a framework and a principle that is invoked and is felt in many European countries. So it's the other side of the autonomy debate. I think there's still autonomy in presumed consent because you could say no. The individual is honored by being able to opt out.
What's the fear? Is the fear that people will be declared dead and their organs will be harvested before they actually are dead?
Well, let me give you an example, because Singapore went ahead and they had a low donor rate. They went ahead and invoked a presumed consent, but they didn't give a societal option, an easy societal option to say no. They didn't say, okay, we're doing this, but if you don't want to do it, register here. They didn't do that. They just made it a policy. And what clinicians in the intensive care units were finding was that patient was dying or going to die very shortly, and then the families were being informed that that this patient is going to be a donor because they didn't indicate that they didn't want to, and they were negotiating. Families were negotiating with ICU doctors to say, how can we get out of this because we don't want to do this? And so there is the balance between trust of your government in terms of policy and fair balance to the societally beneficial goal of trying to provide transplantable organs. And just to state, I'm on the other side of the line. I'm on the dying, deceased donation side of the line, not on the transplant side.
Okay.
I think you're exactly right. I mean, it's fascinating to see how palliative care grew, and it grew really alongside of a relatively robust hospice presence in the United States. So, the concept of hospice was a non-medical, since it was really started by nurses. It ended up being a home-based, non-medical service for end-of-life care. And palliative care is what I kind of say is the medical industry's response to hospice, but it was in the hospital. So we have relatively robust now services in palliative care that are hospital-based, but very little in terms of outpatient palliative care that most programs are able to actually muster in terms of disease programs. So even from a systems perspective, there's a little bit of confusion, not just on physicians' part. I think there's a bit of confusion on palliative care's part about what it really is. Clearly, studies that look at introducing palliative care to lung cancer patients at the time of diagnosis, study done up in Boston showing an increased survival in the population who got regular treatment plus palliative care compared to the group that got palliative care. I read that and said, what is it that we do that increases survival 3 months in that population? I'm really not sure what it is, but it certainly says that we've got to come, ourselves personally as palliative care experts, have to come to a better understanding of what services are we offering, where do we offer them, when during the course of the illness do we offer them, and what are the real components of them that make a difference in taking care of patients and families.
If I would say one cautionary thing, what I worry about is the retreat of palliative care from an end-of-life context plays into the death denial. And if carried to an extreme where we never do talk about the patient is dying, we never do share a short prognosis, we're just talking about, well, we have this palliative care option, we will rob people of the notice they need that it is time to put an end-of-life plan in order.
And that's why, for me, as I said, the one thing that I'm interested in having in every conversation is the prognosis conversation, because it grounds me in terms of where I'm going, and it allows me the opportunity to be very frank and honest with patients and families about what's ahead.
I think you need to rebrand, Chris. Palliative care has this image in people's mind that we're giving up and you're going to die. And I agree with the question from the audience that in fact it's a lot more than that. And it's not just about relief of suffering before death, it's relief of suffering during the process of treatment that may have a bad outcome. And so I think you need a rebrand. I think you need a social marketer, and you need a...
Yeah.
Brenda just hope. You're not going to die. We're just going to make you feel comfortable.
You might die, but we're gonna make it comfortable for you.
You know, Steve, you talked about cost in the very first question, and we haven't really grabbed a hold of it. And thank you for bringing us back there. And this question brings us squarely there. One of the things that is driving cost in our healthcare system is that new technologies are being introduced without being properly vetted to consider their effectiveness and their cost effectiveness. And our Congress has even said that we're not to look at that. And even the Patient-Centered Outcomes Research Institute, which will be doing excellent research, is not funding data collection on cost.
Can I just push you on this for a moment? Suppose we were to acknowledge what this end-of-life care really does cost. I mean, we look at the numbers and we see, oh my God, I mean, you know, to sustain this person for another 2 months, I mean, it's this kind of cost. What changes? If we actually take that information in, what would alter, what would be changed in terms of how doctors actually care for their patients?
We might decide that extremely expensive chemotherapeutic agents that bring only very marginal benefits, maybe extending life a couple of months, are not worth it. And some institutions are actually making those decisions on their own because we failed to do it as a community. So that's one example where we might decide that it just really isn't worth it to have.
Or less than a
kind of
50% chance.
Only
Only
way less.
or 20% chance of
a
prolonging
tiny,
life
of a
for
tiny,
a month.
a tiny
Right.
amount of time.
Yeah, some of that data actually is already available. It was interesting that we had done some work on the use of growth factors in end-stage cancer patients. So that's EPO and those that keep the blood count up. And it was very common to have these kinds of drugs used in the late stages of cancer treatments or the life of the cancer patient. Joanne Lynn, who did the support study, which is a seminal study published in 1995 about end-of-life interventions, is down looking at Medicare claims. And she called me up and she said, well, I'm looking at the use of growth factors in cancer patients, and it's indicated post-chemotherapy, but I'm never seeing it given during chemotherapy. I'm seeing the charges sent to Medicare 6 months after chemotherapy, which in most of these patients' lifespans was late in the disease course. And I had commented to her that we had looked at the experience of using erythropoietin or EPO, and we couldn't show benefit in these patients. And it's an ungodly expensive intervention. Now, nobody does that anymore because the FDA came out with an advisory that the use of EPO decreases survival in solid tumors, and so no one gives growth factors in this situation. But we haven't gotten used to, especially in end-of-life care, critically looking at the interventions that we give to see if there is a benefit. And if there is a benefit, can we justify the clinical use of the medication for the patient's benefit? And I haven't even gotten into the cost issue yet. So it really is, it's out there and it is searchable, it's understandable, but it requires a tremendous amount of interest on people's parts to collect the information and start looking.
One of the projects that we've undertaken is building a coalition to battle unwanted medical treatment that is clearly in violation of a person's wishes. If they had been alert and had been able to get an informed opinion about what it entailed, they would not have consented to it, and their advance directive clearly documents that. Yet their advance directive was violated, charges added up. Sometimes those charges are many hundreds of thousands of dollars. Currently, CMS doesn't even ask, did this treatment comport with a patient's advance directive? If we could just put that kind of a screen in place, would the patient have consented to it? Did the patient, in fact, try to refuse to consent to treatment such as this in advance, and that attempt to refusal failed? Was this unnecessary, unwanted? It never should have happened. It could be what Medicare calls a never event. We're not going to reimburse for it.
We're starting to run short of time, so I want to. Millie, do you want to have a quick comment
I
here?
just want to say that I don't think it's a good idea to leave the room and think that end-of-life care is the major reason for our health care costs escalating. It's a significant part, but you know, most people in the room may have heard the statistic that about 27% of Medicare costs are due to the last year of life treatments. But that has been a steady statistic, 27%, for a long, long time, even while the growth of healthcare costs has continued to go up. So there's a difference there, and it doesn't have to do with our end-of-life care. So we know that palliative care studies show that there's the potential for survival. There is also the potential for cost savings. So it's a part of the picture. But we have escalating healthcare costs for a lot of other reasons, and one of them is the introduction of these technologies without any comparative effectiveness studies. That's one reason. And the other is our fee-for-service system, in which we are rewarding and paying by piecemeal, basically piecework. You know, the more procedures we do, the more healthcare organizations' revenues come in. So that's also shifting. We're going to be designing things that have capitated payment reforms. But as long as we have a fee-for-service system, there's an incentive to do more things. It's not appropriate when people are clinically depressed, for example. And all these laws ask to be, there are mechanisms to ensure that the person who is requesting aid in dying does not have clinical depression. And it would really, in my view, be malpractice to begin to proceed down that line unless somebody really tried to figure out whether that was going on. So that's one difference.
Can you actually draw that line, though? I mean, someone who is terminally ill, and you're going to say, oh, sorry, you're clinically depressed, so you can't end your life?
You can draw the distinction, and it's a clear distinction between situational depression. That is a reaction of sadness. I'm sad, I'm losing everything, I'm losing my life. Sadness would be appropriate. That's not pathological. You can draw the distinction between clinical depression that is a mental illness that impairs judgment. So you can be sad that you're dying, you can be experiencing appropriate grief, but not have impaired judgment. And that's a relatively easy distinction to draw.
I'm fairly confused about the whole issue only from the experience of taking care of patients in a very particular phase of illness. So my experience with patients who are terminal patients, and I'll define that as patients who probably have 6 to 8 weeks to live, a very high percentage of those patients have profound cognitive impairment, and a very high percentage of those patients are delirious, which means that the time for that person to have had discussions about care wishes, that time for that person to have had a cognitive discussion about prognosis is long gone. So the idea of someone having the capacity to make a decision about aiding in death, most of the patients that I run up against and are taking care of and walking through a very difficult journey really have lost the capacity, in my mind, to enter into that decision. So this is a really complex issue about when we talk about this physician-aided death. When in the course of a patient's existence would this occur? And I think that we would be shocked to find out that we'd be talking about decisions that patients are making with an estimated survival of months before they're going to die. So for me, it's a very difficult situation when I recognize that the typical patient with these illnesses that are chronic illnesses that lead to a predictable death often are very, very difficult with cognition and problems with delirium that the patient has.
The other thing we haven't talked about is the huge population of people with Alzheimer's that we're going to have as we're aging. And they're not candidates for aid in dying either, because you have to have the capacity to make this decision. Only capacitated people can be candidates for this. So that's part of the reason I was saying I don't think it's going to be the major solution for us. We're going to have millions of people with dementia. And we have to start to, we haven't talked very much about how we build long-term care facilities that can support the needs that our aging population is going to have. We've talked so much tonight about the acute care setting, but building the social supports for frail and demented our parents and ourselves in the community is going to be a huge challenge.
You know, that's a great question. So there are things that are being done right now in Toronto, for instance, that has a very aggressive and innovative lung transplant program. What they do is that they actually, rather than the urgency of somebody's died, wants to become a donor, you need to remove the organs quickly and you need to transplant them quickly. There's a number of things that happen to organs that make it hard for them to be used or to work, and therefore they're discarded because they can't be used. The lung transplant program at University of Toronto does something called ex vivo lung perfusion, but what they do is they take the organ out and they simulate conditions as if the organ was in the body, meaning it is provided circulation of blood and oxygen, and it is given treatments to repair the function of the organ in a laboratory for 24 hours prior to transplanting it. So the idea of repairing organs, resuscitating organs outside of the body is a big source of potential to improve the availability of organs. And then the other big thing is are we ever going to get to the point where you can actually grow organs in a laboratory? Right now we can grow simple organs, something like a bladder or just a container. But there are fascinating experiments in animals where you can it's a little bit complicated, but basically use the structure of an organ and repopulate it with stem cells that basically recreate the organ. So I think that future is promising. But can you just rephrase your question again? Because I'm not sure I even answered it. Just, can you say that again? Yeah.
If there's like an 80-year-old man and he doesn't have long to live, but I know I have long to live, and he needs a heart transplant. If they can put me into stasis for a certain number of time until the man dies, and they just give him.
And then you take it back.
Right.
There you go.
I don't want you to sign that consent form. I'm just telling you now, I can't explain it, but don't sign the consent form.
I think we have time for one more
question. It's a great
question,
question, but the answer is no.
Maybe the way to start is, and this is very specific to the work that I do, so I don't want to answer outside of that. I think where we start is we start by humbling ourselves as physicians, at least in the work that I do, to understand that the greatest benefit that we do is witness. It's not treat.
Yes.
It's not a medication.
Witness.
It's not an intervention. We witness. And it's amazing to me to watch patients as they near the end and as they're dying, rather than reaching out to the ones that are closest to them, like family, to tell their story, and to have someone around who can observe and witness the significance of not only the events that have happened, but what has gone on before, is a total stranger. And ends up often, if the physician is open to it, to be the physician. And it's a humbling experience to realize that I can't say everything's going to be all right, because it's not going to be. And I can't make promises that I can't keep. But the promise I can keep is to sit and to listen and to experience that. And then I can bring all the rest of my armamentarium with me. If I've started with witness, then I think I've begun to truly know who I'm taking care of. And I can personalize that experience so that the whole way that I do things no longer is at a distance, and it no longer is separated from them, but I walk alongside them. And I think that changes not only the way you communicate, but it changes, I think, the decisions that physicians make.
So, you know, I have to say that I don't think that physician education is the answer at all. We had a 10-year period from the time the support study came out to 2005, when Robert Wood Johnson, Open Society Institute, all grant makers in health, they spent about $350 million on physician education. And it still is tremendously lacking. We don't actually have any measurable improvement in patient-physician communication for all of that. I think that physicians, the medical community, is reactive, it's not proactive. And what it reacts to is changing expectations in the environment of their patients. If you talk with people, physicians who have had this transformational experience and they are now good communicators, it's because of something that they learned from their patients. It's like the natural birthing movement. It's not because obstetricians decided, gee, we're going to change the way we practice deliveries, we're going to create home-like environments, very family-centered, much more natural, less anesthesia, et cetera. No, it wasn't that at all. It was because women said, we are tired of this high technology, of this impersonalization of what is a natural life process. We want to reclaim birthing. And they did it in such a way that the medical establishment responded. And now we have providers competing on the basis of how home-like, how family-centered an environment for birthing they can provide. Well, I think it's going to be the same thing for deathing.
Deathing, I just learned a new word here.
We have to change the expectations of the people and pull the medical community, because you can't push them. You'll have to pull them because society expects a more natural, a more home-like, family-centered, patient-centered dying experience, and that's what we demand.
Millie?
So following on that, what are the things that patients and families can do to encourage that kind of response in clinicians? And I think partly it's giving the clinicians permission to share their uncertainty, to say, look, I realize we might not be clear about the prognosis, but I want you to lay out all of your thinking. I'm not expecting you to tell me black and white answers. I think many clinicians don't know they have that permission, and patients and families can actually give it. I think that there's, along that same line, not just uncertainty, but try to help me understand what might happen after I leave here. I've already mentioned that. There's a lot of things that we can do as patients that encourage the sort of conversation that we've been talking about, and that speaks to the comment that we heard earlier about contemporary issues. Often are families demanding things, and the doctors not really knowing how to, getting into conflict about that. And so that's another thing that the public can take hold of and say, more technology is not necessarily in your loved one's best interest. And how can we be more sophisticated in our understanding of how we take great benefit from the amazing advances in science and technology that are breathtaking, that we want to be doing, and minimize some of the burdens that come with that. That's going to have to be a voice that comes from the public and creates more trust in that clinical encounter.
And Sam, you get the last word.
I'm a intensive care doctor, works in a children's hospital, and families of children who are sick and might die aren't ready for deathing. So it's a little bit different, but I can tell you in my experience, people who manage death regularly, intensive care doctors, palliative care doctors, develop very good communication skills in managing families and trying to address where they're at in their communications. But the reality is the vast majority of doctors in the healthcare system do not have experience in managing death and dying. And so to expect them to have communication skills in this area is naive. It's not going to happen. And so what I hear throughout all this discussion is that currently end-of-life care services are inadequate in society, either in the hospital or at home, and investment in end-of-life care services for those families who require it perhaps is one of the things that we need to do. But communication comes from experience, and if you don't talk to families with dying patients, you don't develop it, so don't expect it. Don't expect it from your cardiac surgeon, don't expect it from your brain surgeon. What you want from them is good hands and good decision making.
We have many more questions, but no more time. Thank you so much to the panelists. Thank you, all of you.